In this video series, we're going to show you an interesting case where a patient had both an intranasal vascular tumor and a pituitary adenoma. First, we're going to address the intranasal vascular lesion. Because the pathology is not yet known, we would not want to combine any potential malignant tumor with a highly suspected benign pituitary lesion. Here you can see the lesion in the nose. A biopsy of a nasal lesion, by custom, is biopsied in the operating room. So there was no reason to perform separate biopsy prior to resection, and therefore the staging. You can see I'm using a tool called an aquamantis. The aquamantis is a bipolar with a self-irrigating system. I'm removing the lesion at its root. It appears to be attached around the roof of the nasal cavity, sort of in the mid or anterior ethmoid region, just medial to the middle turbinate. The lesion's been completely excised with a minimal blood loss due to the careful hemostasis that is possible by using this particular aquamantis technique. Now we're going to remove the pituitary tumor. You can see we've gone back in a few weeks later, and to show you how nicely this region has healed. We have just a little bit of new epithelial mucosal regrowth. Now, to approach a pituitary adenoma, because most surgeons, including myself, are right-handed, we typically go through the right nasal cavity. I'm performing an uncinectomy with a shaver and then performing a complete anterior ethmoidectomy. It is very important to perform a complete ethmoidectomy because we do not want to induce an obstructive pathology to the patient postoperatively when there was none before. Now I have gotten to the back of the nasal cavity and I am opening up the sphenoid sinus. I'm using a drill system to remove the keel and to get a wide exposure of the sphenoid sinus in order to expose the sella. Now you can see the optic nerves are represented in the yellow-orange, the carotid arteries in the red, and the sella turcica and the tumor in the green. The bone is left intact. Over the carotid artery and optic nerves, now I've removed all the bone over the pituitary, protecting the other delicate structures. We're going to make a window through the dura with a sharp endoscopic blade, and then work on the tumor. It is important to get adequate exposure and not work through a small opening. Here we're beginning to open up the tumor and send some tissue for extempora pathology to confirm that it is indeed a benign lesion. Gentle suctioning can remove the soft parts, and curetting is used to remove the remainder of the parts at the margins, inferior and superior aspect of the tumor. Here we can see the last little bits of tumor being removed. You can see the diaphragm sellae is hanging down and gently pulsing, indicating a complete tumor removal. Now, to reconstruct, I have taken a portion of bone from the front of the sphenoid sinus. Because there was no CSF leak, I did not place fat inside the sella. In cases where there is a CSF leak, I will first place some fat through the sellar opening and then place the bone on top of it, but being very careful not to put too much volume inside the sella and cause a compression on that basis. This is a middle turbinate flap being put back into position. I place fat into the sphenoid sinus regardless if there is a CSF leak or not, because it helps to reform a more natural closure and anatomy of the posterior nasal cavity. The second flap that I placed was the nasoseptal flap. So I use a dual flap system, and then I place firm packing of antibiotic-soaked cotton gauzes and nasal trumpets silicone in the nasal cavity to allow for a good, nice opening of the nasal vault during healing. If you rely on dissolvable packing, the healing tends to be delayed and the patient usually requires a prolonged period of debridement while using this dual flap technique to cover all of the fat and to provide a nice open supported cavity. This minimizes the need for post-operative debridements.